So, Justice, you brought us into an area that is obviously one of the bigger questions in terms of the differences in these drugs, which is safety.
Right.
And Dan Martin has said very repeatedly that he doesn't feel there's a safety difference between these drugs. You know, you've read the same study that he is reading from. You know, what is your opinion about the safety between at least Lucentis and Avastin?
I think we don't know the answer yet. I think that we're gaining more and more information. You know, one of the things when IVAN was designed, it was designed to actually be able to be folded into the CAT data so that they actually could do some of the meta-analysis. And at 1 year, they looked at the safety differences and essentially determined that there were some signals that from a serious adverse event standpoint, which is all comers of serious adverse events, that there was a difference, you know, between Avastin and Lucentis. What it meant from a clinical standpoint wasn't clear, and their safety monitoring board determined that it wasn't at a high enough rate to do anything to stop the study. In CAT, when we look at it, the side effects we think about from a theoretical concern, things like stroke and MI, there was no difference between the two. And ironically, in IVAN, when you looked at Lucentis and Avastin in heart failure and MIs, there actually was a statistically significant higher risk in Lucentis compared to Avastin. But the bottom line is the thing that seems to continue to come up is more of this overarching serious adverse events that seem to be higher in the Avastin arms. And what that means, we just don't know, because some of those events haven't been tied to anti-VEGF use, things like hernias, but it is something that's out there. It's something that seems to be consistent. A couple of things that are interesting, you know, Dan talked just yesterday on some of the top 10 things from CAT, and a couple of things that have come out was, one, certainly the IVAN data showed that clearly Avastin seems to reduce serum VEGF levels more than Lucentis, and monthly treatment reduces serum VEGF levels more than discontinuous treatment. From that data, which I haven't seen, but he presented, was that there's no correlation between serum VEGF reduction and adverse events. And so whether or not that's tied in, we're sorting that out. But it's something certainly to continue to watch. The one other thing that the question is this noise, is in most of these, in the discontinuous or PRN arms, the serious adverse events tend to be higher and not in the monthly ones. And what that means, again, you know, we don't know.
But you know, correct me if I'm wrong, but I thought the 2-year CAT study showed that serious adverse events were about 30% higher in the Avastin group compared to the Lucentis arm. I think 31% versus 39%, nearly 40% in the Avastin group. I believe that was significant.
It was definitely. I think that's the thing. It was definitely significant. There's no question. Both at 1 year and 2 years, there's a significant difference. But I think what Dan is saying is that these are not sort of what things we would expect from an anti-VEGF agent. It's not like difference in MI, strokes, etc. It's sort of hospitalizations for GI bleeds and other things. Now, GI bleed may be an anti-VEGF effect, right? I mean, that certainly was seen in the cancer studies.
I mean, I take a humble approach saying that there is a difference, and every study is showing it's not the other way around, where ranibizumab is less safe. Venous thrombotic events were triple in the CAT study compared to Avastin compared to Lucentis. And I took a humble approach saying, you know what, we don't know. But the data is showing what it's showing. And I think you know, we have to advise our patients that there is a difference. We can't explain it, but that there is a difference. And then on top of it, you see what the IVAN data is showing. It's not just a little difference in VEGF suppression systemically. It's a significant suppression. And then on top of it, you throw on the compounding issues. That's a whole other layer of complexity to our choice in advising our patients.
Yeah, I think if you could, you know, look at this, everybody looks at data differently. Obviously, if an Avastin user, you look at CAT and say, well, it looks pretty safe, there's no ATE differences, I'm good to go. But no matter what you say, I think the compounding issues are a big issue.
It's a huge issue.
And certainly if you're going to use Avastin, then make sure you're getting it from a good pharmacy. I know going through Congress right now is a bill to basically certify pharmacies that would be allowed to compound, and they would actually be called compounding manufacturers.
Oh, wow.
They would no longer be called compounding pharmacies. It's something that they would have extra visits by the FDA. They'd also have to pay a fee to the FDA to become a manufacturer. And the interesting thing about the bill is it specifically states, because there's a lot of drugs that get compounded, but it specifically states if you're going to compound Avastin, you have to become a compounding manufacturer. And I think it's good because part of the issue is exactly that, less than scrupulous, shall we say, pharmacies mixing and sending out Avastin. But I also think it's good to have oversight. The unfortunate side effect is the price is probably going to go up because they have to pay the FDA for these visits. So our Avastin will go up. But I actually have heard of several practices that are talking about making clean rooms in their offices to do their own compounding. Have you heard about any of that, or anybody thinking about doing it in their own practice? No?
Well, we're lucky enough we do it sort of within our practice, but not really. I mean, I think there's such a difference in when you're at an academic institution that may have their own pharmacy who's doing it. It's cheating in some ways in terms of a comparison to what the community practice deals with in trying to find a pharmacy that they can trust and all that. I was at a conference in India, and it was very interesting hearing the challenges in a developing country of what they deal with. And someone actually brought up, one of the talks was on how to deal with the Avastin compounding issue, and they do it in their OR. And they have a clean day where they go in and they do it all under sterile conditions. They compound their own, they sterilize it. And it was very interesting hearing essentially, how do you deal with the hurdles of it? The VA system has come up with a different solution. They shut down initial use of Avastin because of the compounding issues and concerns because of an outbreak. And now, at least most recently what I'd heard, I don't know if it's changed, but they were essentially mandating that you use a single vial for every patient, and you're not compounding anymore. It's still a significant difference in cost, but much more expensive than what we deal with. And when you look at reimbursement from Medicare, is not particularly high for Avastin right now either. So it will be an issue if price goes up.
Yeah, and I think all of us, we all use the Avastin. I think we all welcome having some FDA oversight of these pharmacies, because I think that, to me, is the number one safety issue between both Lucentis and Eylea and Avastin. It's the whole compounding.
No question.
Now, what about Lucentis and Eylea? There was one comparison study. Is there any safety differences, any safety signals between those two drugs?
No.
They're found to be essentially equal. There's no statistical differences and no even trends with one versus the other up to 2 years out.
Yeah, so the safety signals aren't there.
Right.
The two are essentially identical. So you have this patient. They walk in to your office. Why don't we do not a one? All right, how about 3 words as opposed to one sentence? What treatment regimen do you do for your treatment naive patient? Walks in, has a regular lesion. How do you treat it? You treat and extend. These are your choices, Jason. Treat and extend, fixed, or PRN.
Eylea, treat, extend.
All right.
That was
seen it.
Eylea fixed in many patients, but Lucentis treat and extend.
So when you say Eylea fixed, you're talking about 3 loading doses and then switching to Q 8 weeks?
Yes, every other month for the first year, and then treat and extend in year 2.
Okay.
So I do Eylea, treat, extend, but if they dry out after the first injection, I start extending them and don't do monthly. I'll go to 6 weeks and 8, and then I'll go up to 10 weeks and maintain them at 10 weeks with Eylea.
So you're doing treat and extend from baseline with Eylea. So if you bring them back in a month, I assume after the first injection, if they're dry, you say you're going already to 6 weeks.
Yeah.
So you're not doing a loading dose like Cena. Do you think a loading dose matters?
If you look at the MANTA study, they and that's the PRN dosing, which they did in Austria, looking at Lucentis and Avastin, they found that they gave them 3 monthly loading doses, and that's when they got their best vision. And when you went to PRN, they dropped 1.5 letters to 2 letters. So I think the loading dose matters to the extent that the best we can measure it with is OCT. So if the OCT is dry after 1 injection, what are you really loading?
Do you think there's loading dose issues?
I don't know. You talk to Dan, you hear Dan talk about it, and Kat did not do loading for PRN. And again, one of my concerns with not loading is there an element of you could have hit a higher plateau. And from a vision function correlation, I'm concerned that I might not have hit the plateau that I'm going to hit. I have no data for that, but it's just when you look at all of the trials, that's the curve, and that's where this idea, came from. And I think it was mandated with Pronto whenever Phil designed it that they were going to do the 3 injections, and that's, you look at Anchor and Marina though, that's where the curve was. So I tend to do 3 loading. I don't always. It depends. But you tend to have this curve with it. So from my for your patient scenario, is their other eye's good?
So I'm sorry, the other eye was good. So why don't you answer the question we asked?
So I let the patient choose, and
let the patient choose. Then you're done.
But from a regimen standpoint, I do a modified PRN where I start PRN, and it's based on how they recur, whether or not I shift them to treat and extend or keep them in PRN. So if they recur with significant edema and vision loss, I shift to treat and extend. If it's a very minimal amount of edema that doesn't have an impact on vision and they don't even notice it and I'm picking it up on OCT, I keep them on PRN.
So you actually will follow patients monthly?
Yes.
And when you say let the patient choose, it's very interesting because we are doctors. We can convince a patient to do whatever we want.
That's right.
It's how we present it. So when you say let the patient choose, how do you what's your discussion that you have with the patient?
So, I mean, obviously in the end, you end up guiding their decision 90% of the time. There are people, I tell them essentially that we have 3 drugs that seem to do an outstanding job of improving vision compared to what we had before. Give them as a pretty brief overview that we have 2 that are FDA approved that have the best safety data out there, and also talk with them a little bit about cost. And sometimes that has a big effect, sometimes it doesn't. And if they have no preference whatsoever, oftentimes I start with Avastin and then see what their treatment response is.
So I personally am what you guys are doing. I do Eylea treat and extend from baseline. I actually do it from baseline like you do, where I don't do a loading necessarily. But if you think about it, it kind of is a loading because you do baseline, you bring them back in a month for sure to get injected at a month, and then the next time is either a month or 6 weeks. Yeah, so I missed the loading by maybe 2 weeks doing this method. So it's essentially a loading dose. What about if it's a second eye? Does that matter to you in your choice of treatment? So the first eye, let's say, has geographic atrophy or disciform scar. This is your second eye. Also treat and extend, also Eylea, or do you switch it up?
Yes.
Thank you.
I'll actually answer something a little longer than that. I don't, as I said, I mean, my goal, whether it's first eye or second eye, is to get a regimen that keeps the person dry. So in asking the question, you're making an assumption that that you might be less attentive to a first eye than a second eye. There's an inherent kind of underlying part to that question, and my attitude is I'm very attentive to the first eye because you don't know when that first eye is going to be the better eye down the line. And I mean, we're all dealing with that, where you had an eye that may have walked in 2060 and the other eye was 2020, and now we're 5 years later, the second eye has gone on and gotten atrophy or presented with a hemorrhage or something, and that first eye that you were very aggressive with is now their better eye. So I think that it's wrong to kind of look at it as a first eye, second eye.
Okay.
My attitude is approach it aggressively. And just to go with one of the overarching themes that we're seeing here, since everybody kind of answered a little differently, the problem we face is we are all trying to make decisions on clinical trial data, which takes a group of hundreds of individual eyes, puts them into a group, gets you a mean or median, shows you a curve, and then you're supposed to decide based on that what to do with that patient. And I think that that's the problem with, I get frustrated when I hear colleagues say, I always do this. Right? We're not hearing that at this table, but I think a lot of our colleagues, well, I always do this approach with this drug. My patients aren't like that. I don't think any patient is like that. So I think we have to take the clinical trial data, whether it's monthly or PRN, whether it's Avastin, Lucentis, or Eylea, and try to figure out for that individual patient where it falls. And that may be monthly. It may be treat and extend from day one. The hard part is looking at curves for means of hundreds and then applying it to one is very, very hard.
Yeah. for me, speaking of the first and second eye, I think what you're saying, Jason, is exactly right in terms of one of the things I'm always telling them, if they come in and they are on a PRN regimen and they don't want a shot and they have this little bit of fluid, is I tell them, I don't know if this is going to be your best eye. We have to keep it that way. The one flip side to it for me, being someone who often starts with PRN, is that if they come in with their second eye and they already have a disciform scars, I may push harder. And I always tell them that what we know is that at 2 years, PRN is not quite as good as monthly treatment. We don't know where treat and extend lies in the comparison of those, but we know that under treatment, and so I will push them harder towards we should just keep you on treatment. And
the one perspective I'd like to share about patients with bilateral disease is that if you can successfully get a patient to every other month Q8 dosing with EYLEA, a patient with bilateral disease, and I have many of these, I see them every month. And they get one eye treated, they get the other eye treated. One eye treated, the other eye treated. But there were times before aflibercept that patients would come in for Avastin or Lucentis every 2 weeks. I had several patients like this in my practice. So the dosing regimen of fixed every other month is a godsend to some of these patients. They can plan their lives, their caregivers bring them to the office, their vacations. So especially the patients with bilateral disease, the happiness level has gone up in those patients when switching them over to aflibercept. So the predictability of when the appointments are.
Do you do bilateral injections?
No, I don't.
Okay.
So do you do bilateral injections?
I do based on patient request.
And so do you do bilateral all drugs? So the reason I ask that is obviously EYLEA and Lucentis will be very different than bilateral Avastin.
It depends on sort of where you're at. So in one of the places I have a little bit more control of which lots are used. So for example, I will do it for all drugs. But I'm much more comfortable when I'm able to use separate lots of Avastin, and I'm able to do that at one of the sites. You can't really do that with Lucentis and EYLEA because you don't have that control. But it is a concern. And one of the things, I never do bilaterals from the beginning, but I will tell patients if this is something, I'm never going to ask it of you. Mm-hmm. But if from a convenience standpoint, that 2 week it's a huge burden.
It's huge.
And so it is something that I didn't think I would do as much starting practice, and now when you have as many people with bilateral disease, it's a real challenge.
I believe a quarter of retina specialists do bilateral injections. I mean, many of our respected colleagues do it. I have nothing against it. It's just with the concerns in compounding pharmacies, safety issues, and also none of our trials really investigated systemic safety with bilateral injections. Right. And you look at the Rise and Ride DME data, and there's some, in the higher dose in 0.5 milligrams, it looks like that there may be some higher systemic adverse events. And so I think until we have more data, I prefer not doing bilateral injections, but I think in the rare circumstance, I'm happy to do it, but with extra precaution.
I would just point out the one maybe positive statistical thing that came out of Harbor was the safety of a 4 times dosage of Lucentis. So certainly it makes you a lot more comfortable if you're doing bilateral Lucentis from a systemic exposure point of view that 4 times the dosage was safe. So giving a bilateral injection the same day seems to be within that safety profile. And I have to say it's the number one thing I got out of Harbor was it was safe. So it's like, good, I can keep doing bilateral Lucentis if I want, and by kind of extrapolation, bilateral EYLEA. I think the Avastin issue is critical, and since the first suspicion about compounding issues came up, we've made it a policy to do separate lots. We will not do bilateral unless they're separate lots.
And that was an issue in the outbreaks. There were a couple of bilateral endophthalmitis cases, and it's devastating.
Same lot. Yeah.